From the Leslie Dan Faculty of Pharmacy at the University of Toronto, this is the I'm Pharmacy podcast. And I'm Mina Tadros. Welcome back. This episode, we dive into part 2 of our final episodes of the season, asking to consider this. Today, we build on the last episode's conversation about flaws and concerns about how we move forward with innovation. I wanted to dive a little bit deeper into who is left behind and what that could mean for innovation. After all, as we push the boundaries of what's possible in medicine, it's essential to ensure that those breakthroughs benefit everyone and not just a select few. I believe deep in my heart that no one wants to make a breakthrough in health that only benefits a few. When it comes to drug discovery and health technologies, focusing on equity means creating opportunities that are accessible and effective for all, including those who have been historically overlooked, underserved, or just left behind. To start this conversation, I spoke with Professor Jaris Swidrovich here at the Leslie Dan Faculty of Pharmacy.
I am Jaris Swidrovich, Assistant Professor in the Teaching Stream at the Leslie Dan Faculty of Pharmacy, the University of Toronto. I am also the faculty's Indigenous Engagement Lead and the founder and chair of the Indigenous Pharmacy Professionals of Canada.
So, when someone asks you in a social setting, what do you do? Aside from teaching and being a professor, what is your research and what kind of questions are you asking?
Yeah, well, I would usually just say, well, I'm a pharmacist and a faculty member at the University of Toronto and kind of leave it there. But if someone doesn't fully understand what that means, if they're not in the same kind of world, then I will expand on the type of research that I do and the teaching that I do. And it's a little bit of a potpourri of topics, especially in the eyes of others. But the way I see it is it really all boils down to either Indigenous people's health or 2S LGBTQ plus people's health, and sometimes the combination thereof. So it very much is all about folks who are made marginalized in our communities. And that's my main focus.
It's one of those things like we've done a good enough job that we've covered that those populations are marginalized. I think most people would agree. How does that affect their health?
Yeah. So, the folks who have been made marginalized over time, this isn't a new phenomenon. So right back to colonization is how I think of things. There were absolutely the first peoples here, First Nations and Inuit initially, and then later was the birth of the Métis Nation as well. But there was no diversity, let's say, way back when, prior to colonization in the land we now call Canada. But now there's extraordinary, wonderful diversity. But over time, this hierarchy, this supremacy of, the dominant population has taken over, and it's kept the first peoples marginalized, even quite literally to geographic extents, right? Yeah. Like about 50% of First Nations still live on reserve in Canada, where access to almost anything is difficult, right? And then for the other side of things that I focused on, 2S LGBTQ plus folks, we're seeing a rise again in hate all around the world. Some folks turn to the United States, but it's happening everywhere. So folks are scared who exhibit these identities, and for many reasons, they don't want to even either leave home or leave their community or access any kind of care, let alone pharmacy care or medical care. And I want to change that.
So it sounds like this is a big problem. Where do you even start?
That's a very difficult question of where to start. So thankfully, I'm walking in the paths made by so many folks before me, even people who aren't in the research world, but who've paved this path for me too. But I'm using my own niche areas of being a pharmacist, someone who is Indigenous, queer, and two-spirit myself, and using my own identities and communities and friendships and connections to ask them what are the questions, right? Kind of the foundational part of Indigenous research is that I don't ask the questions. It should be community driven. Even though I am very much part of those communities, I live a different life than everybody, right? You know, it's kind of an ivory tower in some senses as a academic. So I take myself to community and ask, what's a priority? Or after a period of time in this profession, as I have had, they will just already know me and say, hey, Jaris, you know, we have this problem going on. Can you help us? And that's basically how the questions are asked.
Yeah. So what are the questions that they're asking?
So one right now is particularly in the greater Toronto area, the GTA. We have heard from Indigenous folks as well as non-Indigenous folks and non-Indigenous providers in the realm of HIV who have told us that there is a massive unawareness of PrEP, for example, pre-exposure prophylaxis for HIV. And any folks I know who dispense PrEP, who have clinics about PrEP or even active treatment for HIV, they've said to me they have either zero or like few, like 3 Indigenous folks who access services from them. Yeah. So when I have made relationships over time with Two-Spirited People of the First Nations, a local community-based organization in Toronto, they too have shared we need to do something about HIV, specifically here. I mean, everywhere, but absolutely here. Yeah. And we're sitting at a point, what I've heard from them is that people don't even know about it, right? So for us as pharmacists in the healthcare system, I'm thinking to tailor our interventions, our promotion, awareness campaigns for Indigenous folks. Clearly it hasn't been working, right? So before we go ahead and do something, we need to find out more information. So a graduate student of mine and I, Timothy Lim, we're working on finding out exactly that. Like, what are the barriers, facilitators, opportunities for PrEP for urban Indigenous folks in the GTA? And so once we hear from the community about, you know, why don't you know about it? Or if you do know about it, how did you find out? Or if you're not taking it and do know about it, why? Or if you are taking it, why? And why are you still taking it? Do you think other folks in your community should take it? Who knows what we'll find out? And then the knowledge translation, knowledge mobilization activities will come after that. But first we need to find some answers to those questions.
Yeah, absolutely. Can I ask some naive questions?
Please.
So, you know, over the season, what we heard loud and clear, and it sounds like this is also resonating with some of your work, is that any innovation that happens without thinking about the end user, whether it's the clinician or the patients themselves, is bound to fail. And it sounds like there's some sort of failure here that's happening because there's these great innovations. So in the PrEP case, like really efficacious, it works if the person gets it. And so although you're going to study what's happening in this scenario, is this a common theme across other drug classes? And what are the common failures? Like why is it not, you know, we have this innovation, it's covered, right? It's paid for. So it's not the money issue theoretically. Yeah. What's getting in the way?
Yeah. So I'm thinking of those 2 major patient populations when you were asking that question. So on the Indigenous side of things, I think that even before the drugs and devices and innovations themselves is just the healthcare system, period, right? So we have lived in a country and still live in a country that has not taken good care of Indigenous peoples. For example, when it comes to vaccinations, back in the day, not even that long ago, Indigenous folks were experimented on by the Canadian government and other institutions for the BCG vaccine for tuberculosis to see what would happen, and only tested on Indigenous peoples. For folks who attended residential schools, they were intentionally given or intentionally denied certain nutrients for a period of years to see what would happen. And then that later actually led to the Canada Food Guide, which is based in some of those very racist practices. On the Indigenous side of things, on the 2S LGBTQ+ side of things, stigma too, with any of those identities being Two-Spirit, lesbian, gay, bisexual, transgender, and other sexual and gender diverse identities. Stigma is everywhere. And I just mentioned a bomb threat for drag story time for children, right, in Northern Ontario. So people who exhibit and encompass any one or more of these identities, it's we're thinking of questions of, do I even present myself to the system at all? Like, never mind the drugs, and innovations and devices and all of that themselves.
Yeah.
Sometimes there's just a lot in the way for us to even present to the system. I think it comes down to stigma, a history and current practice of mistrust, even on the Indigenous and women side of things. We're still seeing forced and coerced sterilization of Indigenous women in Canada. People who are presenting for a surgery, let's say an appendix surgery, and they sign a consent form saying, yes, please take my appendix out. But what they weren't told was that a line was also added to, please tie my tubes, like, please sterilize me. And then they're not informed. They sign it and then find out later after surgery that they are sterile. They can no longer have children. And this is still happening. In fact, my home city of Saskatoon, just a couple of years ago, put on their own press conference announcing that they have been doing this. So it's not just like something through the grapevine. The system itself is endorsing, yes, we have been doing this up until this current day and age. So when you're an Indigenous person, an Indigenous woman, and then adding on some of those other intersectional identities, there's a lot of reasons why you wouldn't even approach the system in the first place. But then once you do, and if you do, then now we're faced with the reasons why there might not be certain medications or medication information that is tailored to such folks, or having pharmacists and other health professionals being prepared to chat with such folks about what they're accessing.
So in your opinion, and your colleagues and people who think about this much more than most of us do, what is the path forward to make it better? Like, what does that look like? I think like I'm notorious for this. My research points out problems, and I've been told like, what okay, so that's great. Like, what's the solution here? So what are people thinking is like the path forward? Yeah.
So one phrase comes to mind, and that's nothing about us without us. And we use this in the Indigenous community consistently. I will honor, though, that we borrowed that term from the disability community who used that phrasing first. But we found that it really resonates within our own communities, too. We have a long history of things being done for Indigenous peoples, or what we would often phrase as a white savior complex, right? Of, oh, geez, I'm very well-meaning. I'm a great person. There's all of these issues in the Indigenous community. I want to help. But the best way that you can help is a with, not a for type of philosophy. I often rephrase that for people who maybe it doesn't make perfect sense. It's like if I showed up to your house one day and said, hey, Mina, like my colleagues and I across the country, actually across the world, have solved your family's problems. And we just showed up one day and have the answer for you. You'd be like, okay, sorry, who are you? And what are our problems? Can you tell me more? Right? So that's kind of how we have felt this whole time. So Indigenous folks need to be part of every stage of the process of identifying the problem, studying the problem, what solutions help, what solutions don't help, and then the rollout, and then the marketing and the delivery. All of this work needs to be Indigenous led, and if not Indigenous led, at least Indigenous co-led. So I think that that's the main answer here. We have bright, wonderful people in so many areas of the health disciplines who are Indigenous, and often we're not invited to such tables for those solutions, but we're often told about what our own problems are. But that's what needs to change.
In chatting with Professor Swidrovich, it was very obvious that inequity was apparent in the later life cycle of innovations. But is this true for early parts of the innovation cycle, in drug development and formulation? To explore this, I spoke with Dr. Hagar Labouta, an assistant professor here at the Leslie Dan Faculty of Pharmacy.
I'm Hagar Labouta. I'm a scientist at Unity Health Toronto, and I'm assistant professor here at the Faculty of Pharmacy. And I also have adjunct position in biomedical engineering at UFT.
What kind of questions do you ask, and what interests you?
I'm a nanomedicine researcher. I'm a formulator. Drug delivery is my major focus. So what I'm interested in doing is to try to come up with novel drug delivery systems, in this case nanoparticles, in order to breach biological barriers to reach target sites, so that we are getting higher efficacy and lower side effects. My field has been focusing on cancer, which is a very important issue. It's a very important clinical need. And then when I started my lab, I thought like, well, there are a lot of clinical needs that haven't been addressed. And women's health was always in the back of my brain. My dad was a pharmaceutical chemistry professor, but he was also doing lots of projects in Africa and in the Middle East with the WHO that are sometimes related to women's health. And one time he invited me to give a talk in the Women's Health Center in Alexandria. And that was like fascinating. But again, it was, not really what I was doing at that time. I was doing like skin drug delivery, etc. But when I started my research, the first collaboration that I started was the Children's Hospital. And they were interested in things related to congenital anomalies, which is one of the things that I'm interested in right now. And this really triggered or shifted my research focus. So right now, what really interests me the most is to use my experience, which is drug delivery technology, in addressing or in developing safe and effective therapies during pregnancy. Pregnant women are like very understudied. There are lots of challenges recruiting this population in clinical studies. There's not a lot of evidence on the efficacy and safety of many drugs during pregnancy. Mostly it's based on culture, or like this drug has been used for so long, so let's continue using it. But there is no evidence on the safety and efficacy of many drugs. So this is really what triggers me, is to really use my experience in areas that are understudied.
Yeah. One thing that struck me that you said a couple of minutes ago was that most of the people in your space study cancer and not many people study women's health.
Right.
Why?
There is an obvious reason why many people in my field study cancer. And I think this relates to how nanoparticles target the cancer, because it is known that the angiogenic blood vessels surrounding the cancer or the solid tumors, they are leaky. So using nanoparticles in the side, they can accumulate in the tumor tissue. So this is called passive targeting. So probably that was one of the reasons that triggered lots of interest. And also cancer is really a clinical need that we're still trying to defeat. And I don't think we are there yet. But why not women's health? I think it's not just my field. I think it's overall. So, placenta, if we talk about biological barriers, and let's go to the basics. Placenta is the least studied biological barrier, period. There are lots of research questions that are not known. And this is actually a challenge when we are doing our research. To give you an example, placenta is the only biological barrier that is dynamically changing. So the skin is the skin. Always, it's the skin. At least in this area or in one area, it remains the skin with almost no big differences. Placenta is almost a different biological barrier depending on where you are in pregnancy. So how this affects interaction with novel therapies like nanoparticles. Nobody actually has studied that before we started studying how the fusion of cells, which is something that happens during pregnancy, the fusion of trophoblast cells, affect the interaction and uptake of nanoparticles. And we found that there is a big effect. Also, one of the challenges, and I think this is the main challenge, is that this field is underfunded. So I think it's funding plus being understudied in general, and also the ethical challenges. So when you're coming up with a novel therapy, even if you are in the early stages, you are thinking about clinical translation. And when you think about clinical translation or clinical trial, it is so difficult to recruit pregnant women.
Yeah.
And this is something that we are thinking about a lot early on. So, and this really does not probably attract lots of companies.
You've highlighted a few concerns. Obviously there's in disproportionate funding, there's challenges that present. And then obviously, I think there's like both scientific challenges and ethical challenges. Do you think that if you had like a genie and you can wish on something, that by increasing funding, all of three of these problems would kind of solve and you would see greater uptake of research? Is that kind of the space, or is it just this is the way it is. It's a really hard question. So only really smart people should be trying to tackle it. Like, do you know where I'm getting with this? Like that is it a funding issue that'll attract more people to want to study it?
I think it's funding. We are actually trying to convince the people otherwise. We have organized a symposium on women's health this year within our society, which is a controlled release society. This is the International Society for Drug Delivery Research. And we were trying to tell the people that even if you're not really focusing on women's health right now, come attend the symposium, because what you will see is that you have toolkit that you can apply and address other research questions other than what you're focusing on right now. So maybe we are able to trigger an interest in women's health. Yeah. So I don't think it is really the ethical problems that are unsolvable. It's obviously a challenge, but it's more of the funding.
What in your space, when you look out into the future, makes you the most excited? You always work for impact. Like, you want to see what you're working on really creating an impact. In my case, women's health. Mm-hmm. So I hope that like one or more of our drug delivery tools reach translation. Yeah. And by the way, we're not only focusing on nanoparticles. We're also focusing on how to test those nanoparticles. Yeah. And especially when we talk about women's health, one of the challenges is that you cannot recruit women to test novel therapies, or pregnant women. So for this, we're trying to come up with experimental models in the lab so that we don't need to use pregnant women early on in really screening novel therapies. And these tools are the organ on a chip model. So these are small microchips that you can load them with human cells and matrices and expose them to a dynamic flow of fluids to mimic the human pregnancy conditions. Yeah. And these tools, which are the organ on chip tools, they have been approved by the FDA recently as a preclinical tool other than animals. Yeah. Because animals really, you can't really use animals to really accurately replicate human pregnancy. Yeah. So this is one of the things that we're trying to develop as well in the lab, because we know that and nanoparticles by themselves, or just working on developing therapies, may not really reach this impact. Dr. Labouta perfectly described how her work fills important gaps. I asked Professor Swidrovich the same question, but how he would fill gaps in the current healthcare system. So a big question. Mm-hmm. You're given the reins to change anything in any way you want in the healthcare system. We'll limit it there. We don't want to make it too powerful. What do you think would be a game changer?
I think having at least a representative population within the system is what we see in the community too. So it's unfortunate that we have less than 1%, let's say, of all pharmacists in Canada being Indigenous, but 5% minimum of this whole country is Indigenous. Yeah. The same is witnessed in the medical profession. And I would also argue almost every other health science profession, right? So we need to do a lot in that area. And it's not always just about bringing folks in. I argue that if I were to bring in my cousin from Yellow Quill First Nation, wanting to train them as a pharmacist to go back to Yellow Quill First Nation and other communities, although that sounds awesome, I feel like we cognitively assimilate folks during their 4 years of pharmacy and whatever other post-secondary is required by either a very direct or indirect devaluation of Indigenous knowledges and other knowledges that aren't Western. So by the time that person graduates and goes back to their community, they're actually less able to be effective in their own community. And I've found that in my own research and even in my own self as a pharmacist, because no one has given me the tools to solve exactly that question. I need it and I want it, and I still would love an Indigenous pharmacy mentor to help me answer those questions, right? So at least a representative population of us in the health system. But if we're looking through an equity lens, more than 5% of pharmacists and physicians and others would be Indigenous, that it wouldn't just simply match our representation in the country at whole, especially considering the massive inequity or over-representation, right, of Indigenous peoples in the health system.
On this episode, we learned about some of the populations left behind. Left behind as innovation moves forward. And we learned about the researchers that try to fill those gaps here at the University of Toronto. There are approaches to help ensuring that ever-widening health disparities are closed and ensures the promise of new treatment reaches every corner of society, especially those that are often forgotten. We learned about how, when studying health technology, incorporating equity at every portion of the innovation lifecycle means designing tools and systems that help reach diverse needs and contexts and meet people where they are. To me, this is a wonderful way to close out this season, a season where we explored the life of innovation. A life that's important to consider how to achieve the true dream of health technologies and reach those who need it most. And by doing so, we can make sure that those innovations bridge the gap between different populations, fostering a more inclusive and fair and just society. If anything, by doing this, we reach the full potential of an innovation to improve health, save lives, and just make life better. This episode of the I'm Pharmacy podcast was produced by Steve Southon, Kate Richards, and me, Mina Tadros. Musical accompaniment was from Steve Southon and Diego Martinez. This episode was edited by Steve Southon. Special thanks to Professors Jaris Swidrovich and Dr. Hagar Labouta. Just a quick reminder, make sure to subscribe to this podcast wherever you listen to podcasts. And if you don't mind, leave us a 5-star review. And that's a wrap for season 4.
1940s.
Stay tuned for more exciting things coming your way. Stay safe and keep asking questions. Catch you at the next episode.